on your findings, how reliably can MRI and CT distinguish amyloidosis-related spinal changes from degenerative or age-related alteration?
So what we do now is we're doing a retrospective study, and we're looking at all the preoperative MRI and CT scans of our amyloid-positive patients. And what we do is we're doing quite accurate measurements of several morphological parameters on this preoperative MRI and CT scan. And with these measurements, we can likely predict whether a patient will be amyloid positive or negative. And this will guide us in the surgical process where we can possibly take a biopsy during the surgery. And this will lead to the diagnosis of amyloidosis.
What differences did you observe between operated and non-operated spinal levels, and how do these findings influence surgical decision-making in amyloidosis-positive patients?
So this was the most important finding of our study. What we see in a negative patient, so a patient that has no amyloidosis, is that we see a disc degeneration. And this is different in the positive patients, where we see a disc preservation. So there is no flattening of the disc, and there is an isolated ligamentum flavum hypertrophy. So if you come across these patients on the preoperative imaging, you should consider doing biopsy during the surgery.
How do you envision these radiographic insights being integrated into routine clinical practice for earlier diagnosis for improved management of spinal involvement in amyloidosis?
Firstly, our primary job now is making these findings clear to the whole surgical community, to the whole spinal surgical community, that everyone is aware that these morphological changes, specifically with amyloidosis, are linked to amyloidosis, and that surgeons should do a systematic biopsy during the surgery. Furthermore, if there is a history of carpal tunnel syndrome, then that should be an extra alert to do a biopsy during the surgery.